The nose takes pride of place in the centre of our faces and is unavoidably conspicuous both in frontal and profile views. Anatomically, the nose is mostly cartilage with some bony elements. The main structural parts are the nasal septum, which is the vertical cartilage wall separating the nasal airways. The paired tip or alar cartilages have a unique configuration, and as well as giving shape to the tip of the nose, they also comprise the external nasal valve. The paired upper lateral cartilages constitute the middle vault of the nose, and their relationship with the nasal septum creates the internal nasal valve. The paired nasal bones make up the root of the nose, or radix. The nose must never be assessed in isolation, and the prominence of associated features such as the chin and premaxilla, or upper lip, provide a vital context on which aesthetic decisions should be based. Patients with an underprojecting chin will most often see their nose as being larger, rather than recognizing that the lack of chin prominence is as much, if not more, to blame. Examples of chin augmentation and reduction in association with rhinoplasty will be shown later. Male and female noses differ in terms of the ideal aesthetic proportions. Additionally, the nasal shape changes with age, generally increasing in size with the tip starting to droop downwards. Sometimes the nose may be misshapen or deviated as a result of trauma or previous surgery. In my practice, most patients presenting for rhinoplasty have a naturally large nose with a dorsal hump, often with a droopy or downwardly rotated nasal tip, which may or may not be bulbous. The nasal tip, or alar cartilage, is composed of 3 crura: medial, middle, and lateral. The folds between the 3 crura are known as genua. The exact configuration, angulation, and position of the alar cartilages controls the aesthetic characteristics of the nasal tip. The size, shape, and degree of convexity in 2 planes of the lateral crura of the alar cartilage determine whether or not the tip looks bulbous or sculpted. The degree of straightness of the nasal septum determines whether or not the nose looks straight in the frontal view. Deviated nasal septa often have a unidirectional curvature. Sometimes, though, the curvature is S-shaped, and the amount of curvature relates directly to the degree of nasal crookedness. I most often perform open rhinoplasty as I feel it provides my patients with far more predictable outcomes, since it allows direct visualization of nasal structures, enabling precise and meticulous reshaping. Open rhinoplasty is performed under general anesthesia and involves making a small incision across the columella of the nose, which usually heals inconspicuously. The skin is elevated from the alar or tip cartilages, exposing the upper lateral cartilages and nasal bones. The dorsal prominence of the nose is refined by carefully reducing each of its components. This is done under direct vision with a high degree of precision, as it is essential not to remove too much. This maneuver leads to the roof of the nose being opened, and closure of this open roof requires the nasal bones to move inwards, carrying the upper lateral cartilages inwards with them. This is known as infracture. A cross-section taken through the middle nasal vault demonstrates the effect of removing the dorsum of the nose. The open roof thus created is closed by infracture, which allows inward movement of the nasal side walls. Dissection is continued between the 2 alar cartilages, allowing wide exposure of the nasal septum and permitting excellent access for submucous resection of the nasal septal cartilage, or SMR. This septal cartilage is the material of choice for fashioning strips of cartilage known as septal cartilage grafts, which are used to reinforce the nasal valves and also to improve nasal aesthetics. A structural, load-bearing L-shaped septal strut is left behind to support the nasal dorsum and tip, and the mucosa is replaced. I use spreader grafts in almost every rhinoplasty case. They are a great option since they not only help cosmetically by preventing the middle vault of the nose looking pinched, but also lead to increased patency of the internal nasal valve by acting as a spacer between the nasal septum and the upper lateral cartilages, as seen in this cross-sectional view. SMR, or submucous resection of the septum, also helps to correct a deviated nasal septum by removing much of the substance and therefore shape memory of a deviated septum. Additionally, the inherent adverse curvature of the cartilage can be used advantageously in a septal deviation by reinserting the septal cartilage in a reversed orientation, thus correcting the original undesirable shape. The nasal tip is without doubt the most challenging part of the rhinoplasty operation. Generally, tip cartilage reduction is performed by reducing the size of the lateral crura and reinforcing them internally using pieces of previously harvested septal cartilage known as lateral crural strut grafts. Insertion of a final strut of septal cartilage between the medial crura of the alar cartilages can help to upwardly rotate the nasal tip. This type of graft is known as a columellar strut. Scoring and suturing the tip cartilages can help to reinforce the genuar and crispen these natural folds, creating a more sculpted nasal tip. Occasionally, the skin in the tip or supratip region is also carefully thinned, permitting it to shrink further and allow improved tip definition. In summary, effective rhinoplasty surgery involves a complex series of surgical maneuvers which must be tailored to suit the requirements of the individual patient. Here are some examples.